On the call today, just a quick intros. My name is Bill Lopez. I handle business development and technology strategy for our clients. Megan Papaleo is our HIPAA certified healthcare consultant, and Jay Strickland is our organization president. Jay will be keeping an eye on the chat box. So this is our second installment. We did one of these events last week, had really good attendance, and so I always start with, how do we get here? And so HIPAA, came about in 1996. Just a little bit of history here. Nothing has changed since 2013 when they created the omnibus rule. And the omnibus rule was really more about how it was the entry for BAA agreements. It was also created to help practices handle EPHI, how it should be handled, and data encryption. So those were the three most obvious things that came out of the omnibus rule. But since then, nothing has really happened. Nothing's changed. So with that being said, why now? Why is HHS looking at changing the requirements, or I should say, bolstering the requirements of the HIPAA Security Rule? So a lot of that has to do with technology advancements. As far as advancements go, more and more EHRs, just to give you an example, more and more EHRs are cloud-based. More and more healthcare workers are working in a hybrid type environment, which creates risk when they're not working within the confines of their medical practice and they're working remote. Artificial intelligence, automation, all have created gaps or I should say opportunity when it comes to threat behavior. There is an old saying that still applies today: with convenience comes risk. So the more convenient we've made things over time, the higher there's risk. Another example is telehealth. Telehealth continues to evolve with personal devices that patients take home with them, mobile apps, authenticating to portals being weak. Those sort of things all have driven up the likelihood of a threat of some sort of threat activity. Increases in cybercrime. I'm not going to go through a bunch of statistics here. They're all over Google, but one in particular stands out as Change Healthcare. Over 100 million citizens had their information compromised, and that was not even the fault of the medical practice. That was a third party working with this third party supporting many medical practices. So the instances of cybercrime continue to grow. In fact, remember this is an easy one. The industry that is targeted more than any other industry in the world right now from the cyber threat standpoint is healthcare. Healthcare is and it's for all the reasons I've described recently, which is around technology advancements and around how the ecosystems that are leveraged in a healthcare practice are used, or the relationships they have with those ecosystems not being as strong as they should. Common deficiencies really are, and I'm not going to steal any of Megan's thunder here, but it's really how medical practices have adapted or adopted the requirements of the HIPAA Security Rule. And then the new legal precedents that really is a result of cases being lost by HHS. Most recently, I can cite an example in 2021. MD Anderson was sued HHS for $4.5 million, and HHS lost that case because the standards and the way that the language was written in the HIPAA Security Rule just wasn't strong enough to convince a jury to rule in their favor. So they recognize that the HIPAA Security Rule is written too loose, and because of that, because of the loss of legal challenges in the past, they want to bolster it. So I'm going to cover briefly some framework information here. So in order to effectively help medical practices adhere to the requirements of the HIPAA Security Rule, it's important to have a framework. One of the ones that are out there is NIST. Most everyone on this call has probably heard of NIST. It's a very structured based cybersecurity framework used for many industries. HHS 405D is more of a healthcare specific framework that aligns with NIST. It's really focused more on medical practices, and then HHS CPGs are they're minimal based type frameworks, and they're specifically for healthcare organizations. So the way I'll tie this all together is, without the framework, it's kind of hard to have. It's kind of hard to figure out how you're going to get to your destination. Think of it as a map. If you're headed out of town, you've got a destination. If you don't have GPS or you don't have a map, it's going to be really hard to figure out how to get there. And these frameworks really assist in that. I like to also say that cybersecurity is very much like patient care in the sense that the frameworks give us best practices to either reduce risk or improve outcomes. So very similar to healthcare. That's the objective. At this point, I believe handing the ball off to Megan. Megan, the stage is yours.
Awesome. Thank you, Bill. I appreciate it. So we're all here today to sort of figure out what are the proposed changes for HIPAA regulations. And to start with, I wanted to lay the foundation. Right now, the way HIPAA is worded, they have different standards and implementation specifications that are considered either required or addressable. In the past, we've sort of looked as addressable as you must address it, and oftentimes addressing it meant ignoring it. We read that as that doesn't apply to us. Let's address why it doesn't apply to us. And on the grander scale, people felt that addressable meant optional. And what Bill was referring to, a lot of legal precedents, loopholes, some sort of uh, general knowledge in the HIPAA community is that it's kind of loose and gobbledygook. And so people were taking advantage of that. They're taking advantage of the addressable label. So moving forward, everything is required. There's no longer any sort of addressable label because the HIPAA regulators realize, wow, people are really getting around this. They're using it as a loophole. And that was not our intention. Our intention was to provide scalability and flexibility, especially to the smaller businesses. But going forward, everything is going to be considered required. So in their mind, in HIPAA's mind, that's nothing different because they already wanted everything to be required. But in our mind, it is a little bit different. The way that all of HIPAA regulations are basically written out is that there is a standard, and that is something that we want to see a policy for. And then there are implementation specifications. That is how we are going to implement and support the established standard. So I want to go through a couple right now. We know that HIPAA is divided into three different categories of safeguards: administrative, physical, and technical. So let's start with administrative. So we're looking right now at the currently established standards and implementation specifications. It's not bad, it's something we're all very familiar with, but moving forward, they have established a larger number of standards and implementation specifications. You can see the difference is kind of staggering. So this means a whole lot more policies to be written, a whole lot more implementation specifications to be defined and possibly implemented. But what's really important here is that the HIPAA regulators see these proposed standards as more of a clarification than anything. They're saying, we, intended this in the beginning, we've learned our lesson. So now we're being a little bit more granular about all of these standards and implementation specifications. So obviously, this is a lot. These are just the administrative safeguards. We're not going to cover everything, but I do want to take a minute to go through some of the biggest changes that I've seen and the things that I think will affect you all the most. Let's start with really the very beginning. Our first standard is the technology asset inventory. This is always something you were supposed to be doing, which is collecting and keeping an up-to-date inventory of all of your assets, specifically those that stored, processed, or touch patient information. Again, this is clarification. We've already been doing that, but right now with these proposed changes, they want to see that expanded. They want to make sure that you are indicating the person responsible for each asset. They want to make sure that you're indicating where it is. Does it store patient information, and they also want you to include assets that may not store patient information or may not touch patient information, but they support the security of devices that do. So we're looking at an expanded asset list. We want to make sure we're including hardware and software and other technical components. So we can't measure risk if we don't know what we're looking at. So it's sort of an expansion and clarification of the original asset inventory standard. Going along with that and going one step further, a new proposed requirement is what they're calling a network map. This is one of our implementation specifications. This is a visual diagram of the flow of patient information between assets. What's important here is that this is not a network diagram. This is not how does the internet get things? How are things connected? This is how does our patient information flow between assets? And those assets on the network map must include your business associates' assets. So if your data is in Athena, you're in the cloud, you aren't listing that in your technology asset list because that's not your responsibility. You don't own it. It's in the cloud, it's hosted, but it does obviously need to appear in your network map. And then I'm sure, have other business associates. So those all need to be included in the network map. And we want to see the relationships and the flow of patient data because this is going to inform how you do your security risk assessment. We're looking at what are the risks for the different connections and flow points of our patient information. Which brings us to the updated risk analysis standard. This is sort of nothing new. Like I said, everything here is a clarification. We've always had to have an asset inventory. We've always had to look at threats, likelihood, impact, and assess the risk level. I would say the biggest change here is that you are required to assess the risks to your patient information introduced by your business associates. Obviously, that's something we've probably been doing. You should have been doing in the beginning, but it is now a requirement. And the remaining implementation specifications are really driving exactly how a security risk analysis must be done. They are also clarifying that a security risk assessment needs to be done at least once a year. They're saying every 12 months and following any large events or changes in your organization. That is something that we've been inferring from legal precedents in the past because, like Bill said, HIPAA really hasn't been updated since 2013. So again, a clarification and sort of supporting what we've assumed to be best practices in the past. One of the we already talked about this, the risk assessment, including business associates. We all know that it's important to reduce the attack surface. We want to make sure that all of our employees, all of our business associates, any individual or service is only given the correct amount of access needed. That's nothing new. We all need to know, we all know least privilege. But the biggest change to the workforce security standard is the implementation specification called notification. This is the requirement that this is a proposed requirement that you would alert your third parties to which your employees and or users have access changes to within 24 hours. So following termination or any other sort of access level change, if that individual had access to a database, a system, et cetera, that you do not control, you would be required to provide notification to that organization within 24 hours of that change being made. This has always been a good idea. If we have a doctor that we're employing that also has admitting rights to the hospital, clearly we want to tell the hospital if we've ended our relationship with the doctor, something like that. But this is now being codified or being proposed to be codified, that we would provide notification of access level changes to organizations within 24 hours of that access level change. Security incident procedures are something that we've been talking about for years. I'm sure everyone is sick of hearing about the importance of a security incident response plan. However, it is now being proposed to be required. The idea of the security incident response plan is that you would have a written plan on how you would respond to a security incident, including a cybersecurity incident, to mitigate the effects, stop the attack, preserve the data, communicate with necessary parties, keep your business running, keep providing services to your patients, and then get everything back and running within 72 hours. The important part here is that it is now being or proposed to be required to have a security incident response plan, again, documented and then tested at least annually, every 12 months and or following major events. What we want to see here is that the plan is documented. You have a security incident response team. They know what is required of them. And then you're doing a tabletop exercise at least every 12 months. Always a great idea, but soon to be possibly required. Along those lines, a contingency plan is something that's always been required, and they are just sort of giving us some context and again, clarification. The biggest change here is that while we've always been required to have a contingency plan, which is how we are going to provide services and continue working through an emergency and how we are going to recover from that emergency using our disaster recovery plan. The big change here is that there is a requirement that your contingency and disaster recovery plan gets you back up and running within 72 hours of conclusion of your emergency. So in the past, it was just how are you going to provide services and how are you going to get things back to normal? But now we're sort of putting a compliance timeline on there. How are you going to do all that within 72 hours of conclusion of your emergency? And again, we want to see testing and revision following that test. We want to see a tabletop exercise at least every 12 months where you're running through, let's pretend that this happened. How are we going to do this? Who's going to do this? Who's going to contact our third party? What is our process for this and that? We want to see that plan tested every 12 months and updated according to what went right and what went wrong during your tabletop test. Another additional, I should say, standard is proposed to be a compliance audit. This seems obvious, but it is now or would be required to do a audit of your HIPAA compliance at least every 12 months. So we were already talking about a security risk assessment every 12 months, and that's looking for risks to your IT environment. But they also want to see that you're looking at your HIPAA compliance every 12 months. So reviewing your policies and procedures, making sure that you have an established and written policy for each of the standards and implementation specifications, and that you are actively implementing and have fully deployed all of the described standards and implementation specifications. Another big change that is less of a clarification and more of a workflow change that is proposed is the necessity for a once annual written verification of your business associate compliance. So basically, what this implementation specification is saying, like, you get your business associate contract or associate agreement signed when you bring on this new business associate. You're looking at the risks of introducing this business associate into your agreement. But once a year, every 12 months, we need to start obtaining written verification from that business associate that they are indeed compliant. We all know that business associates are held to the same HIPAA regulations as covered entities, which means they must also be doing the once annual security risk assessment, the once annual compliance audit, the annual security incident response testing, the annual contingency and disaster recovery training, annual HIPAA training for their employees, recurring security risk assessment or security awareness training for their employees. Our business associates are held to the same standards as the covered entities. So once a year, we need to be obtaining written verification that they are indeed maintaining their compliance status so that we know that our patient information is being protected when it's in the hands or being handled by our business associates. So that is a major change, but honestly, a great idea. And then another sort of clarification that has been written into these proposed changes is the ability to delegate to your business associate. So in the past, we've always said you have to have a person or people in charge of handling HIPAA compliancy. We need to see either a HIPAA officer, a security officer, and or a privacy officer who oversees all of your HIPAA compliance requirements and actions. In the proposed modifications, there is a clarification that you can indeed use a business associate to act as your security official. So they would be responsible for managing your compliance and HIPAA actions and responsibilities. However, the regulations are very clear that your organization, even if you're leveraging a business associate, your organization remains liable. And as we always say, you can't outsource accountability. So this is a great clarification for things that we always wanted clarification on. Bill, do you have something to add?
Yeah, let's see here. Just it's a good point to take a quick pause. Haven't seen any questions yet in the chat room. Again, please feel free to do so. And I'm going to go ahead and ask a question. First person that gives the answer in the chat window will win a $25 Amazon gift card. The question is, what year was the omnibus rule created? Thank you.
Awesome. This is my answers coming in. Um, I'm going to hop right back in. We just covered all the administrative safeguards. As we said, there are administrative safeguards, physical safeguards, and technical safeguards. So I just wanted to take a quick minute to talk about physical safeguards. Um, there isn't much of a change in the current to proposed regulations, so I'm not going to spend much time here. I think the biggest thing that we need to think about when we are looking at these proposed changes is that the landscape of physical security has changed. The requirements for securing it really hasn't changed. We all know we need to make it secure. We need to make sure that only the authorized people can access what they're authorized to access. But in the past, when this was written, 1996 to 2013, um, all of our patient information was in charts, folders, and maybe a server, maybe a computer. Everything now is so mobile that the landscape of physical security has expanded to include just about everything. We have mobile tablets, laptops, phones to think about, Wi-Fi, unsecure Wi-Fi, things like that. So while the requirements for physical security really haven't changed, the landscape itself has changed. So I'm really not going to spend much time there and want to skip right on down to the third safeguard, which is the technical safeguards. As we can see in the past, there really weren't that many standards and implementation specifications, and they've added a few more. Again, it's clarification. Um, we're looking to clarify exactly what was intended and sort of keep up with the way technology has changed. Again, this is too much to go through right now, so I'm just going to take a few that I think are the biggest changes and will have the most impact on our businesses. The first of which being the necessity for encryption and decryption. This was in the current regulations considered addressable, which again read as optional for many that we would encrypt data. But again, clarification, they're clarifying that nowadays multi-factor authentic or encryption is sort of standard. It's sort of baseline. It's obviously best practice. So it is sort of understood that the new requirements would be that everything that stores patient information and or processes patient information would be encrypted. So we want to see obviously servers, laptops, computers, phones like that encrypted, but we also want to make sure that software that is processing, transmitting our patient information is utilizing encryption, and we want to make sure that our hardware is encrypted. They have written out a few exceptions, and I would just say that these exceptions are designed to be temporary because, again, encryption is considered best practice nowadays, and then moving forward, it will continue to be best practice and sort of expected. So there are a few exceptions for encryption that say, like, if you are currently using an asset that does not support encryption, you can continue to do so, but you do need to make a plan to move to a new asset that does support encryption. And they're very specific that you can't just make a plan and make no action. If they find out that you made a plan, but you weren't taking actions or making steps towards executing that plan, you'll be in big trouble. There is also an exception for the unruly patient that might insist on receiving their own patient information via unsecure manner. So there's exception for that. We all know how that goes. And then during emergencies, we can make some exceptions there. But again, exceptions to the encryption implementation specification are designed to be temporary. Moving forward, we're expecting everything to be encrypted. And that's for the best of our patient information, our patient security. Um, Another sort of big change that is the proposed necessity of multi-factor authentication. So multi-factor authentication is when you provide your credentials and then you're required to provide another factor of authentication. So that's something you know, something you have, something you are. Many of us are familiar with multi-factor authentication. We use it for our banks. We might use it for our systems. Hopefully we're using it in a lot of places where valuable information is kept. And typically that means we're getting a code on an app on our phone that we're entering to authenticate and show that we are the person that we say we are when we are trying to access that valuable information. So again, it's become multi-factor authentication. MFA has become best practice, but with the proposed changes to HIPAA regulation, it will be required to implement MFA for access to patient information. So if you at the smallest scale, I would say is we definitely want to see multi-factor authentication on your EHR systems. If they don't support it yet, we anticipate that they will soon support it because they also have to keep up with HIPAA regulations. So we want to make sure that MFA is enabled for anything that has access to patient information, which EHR, but then if you have a server or file shares, cloud systems, we want to see multi-factor authentication implemented for that access. Again, there are some exceptions written into these regulations, and again, they are designed to be temporary. You can make a plan to move from an asset that does not support multi-factor authentication to a new asset that does support MFA. Again, you need to make headway on that. You can't just create a plan, but the documented requirements would be MFA for any asset or access to any asset that contains patient information. And that's a big change because that is nowhere written in current regulation. Another big change is the implementation specification of automated scans. Basically, what they're saying here is twice a year, we want to see some vulnerability scanning, automated vulnerability scanning of your environment. The idea here is that technology is changing, the bad actors are getting smarter, they're getting quicker. We can't really rely on just our once a year security risk assessment to do any sort of vulnerability scanning. We want to see automated scans at least twice a year to identify any new or previously ignored vulnerabilities. We want to catch them before they catch us. So this is a major change. But again, a great idea. And then another major change, and kind of like the talk of the town, I think, is the proposed requirements for annual penetration testing. So penetration testing goes a little bit further than a vulnerability scan. A vulnerability scan, what we just talked about, is an automated scan. We're looking for known vulnerabilities. A penetration test is completed by somebody with experience in ethical hacking. It is completed using a human to look for holes in your environment, try to access things that they should not be able to access. This is a major change. We've sort of started talking about penetration testing as what we would assume to be a requirement because we are seeing it on so many cyber insurance liability questionnaires. Have you completed a penetration test that we've started saying, wow, I think this might be a requirement moving forward. And here we are in the proposed HIPAA regulation updates, there would be a requirement to do an annual penetration test. So once again, major change. Oh, and I have a pop quiz. So first person to answer this question correctly will get a $25 gift card. I tried to put some hints in here while I was talking, but HIPAA regulations are written to require regulated entities to comply with these two categories. And I've been saying it over and over again, standards and blank blank, which support the established standards. So first person to answer correctly in the chat box will get a $25 gift card. So I know I've been talking and talking and talking and talking in circles, and the reason why we are sharing this information now, we feel it is very important to one, know exactly what the proposed changes are because they could very easily be implemented soon. So this is our implementation timeline. The proposed changes were released December 2024. Bill, did you have something to add?
I'm just going to chime in after we've got a couple of questions in the chat box.
Perfect. Yes.
Some of them are around this timeline.
Yes, the timeline is great. So one of the questions, when do we need to be compliant? Great question. So the proposed changes were released in 2024. We essentially have until March 7th to submit a comment. So basically, we are right now in the comment period where we can say, we agree, we disagree, this is how we feel. So that is why we wanted to get this information out now, because we are preparing our own comment and we are here to accept your thoughts and see how everyone feels and include thoughts and opinions in our own comment and invite you to submit your own comments. Following the comment period, the basically lawmaking regulations say that changes, well, major changes to these regulations would have to be reviewed by the president or a residing body, but clarifications, small changes do not need to be approved or reviewed by a larger body. We think that the way that these regulations were written were specifically so that they could get away with just pushing them through. So we are anticipating that these rules, these proposed modifications, will actually be published and published pretty quickly. So that's why we want to get this out now. Once they are published on this unknown date, 60 days following that published date of the finalized rules is when they go into effect. So that's when they become law. 180 days after that is when we are required to be compliant. So from the date the finalized rules are published, we have 240 days to be compliant. And that means having our policies and procedures written, implementing all of the standards and implementation specifications, etc. So we have only 240 days from published date. And because we feel like these regulations very easily could be pushed through pretty quickly, that's why we wanted to get this information out now, because 240 days is not a lot of time, especially when we're talking about major changes to workflows and or products that need to be planned for. Another question about, oh, and I guess before I go too far, these are the links. We'll send them out to you all to submit your own comment. Like I said, we're in a comment period now. Basically, they're saying, let us know what you think, but give us great reasons why. You can read the current comments that are out there and submit your thoughts on whether you agree or if there's specific parts that you would like to see changed. I'll also include the links so that you can read the proposed regulations on your own. So please, if you haven't submitted a question, go ahead and submit it now, and we will go ahead and see what questions we can answer for you all. If you do have questions that come up later, we do invite you to email us, reach out to us. We're more than happy to be of service and give you as much knowledge as we have currently.
Again, there's another question in the chat room. Are there changes to BAAs and notice of privacy practice content?
Yes, yes, there is. So that I don't think I covered that, but there are specific changes to business associates agreements that would be expected. They have provided additional time on that specific implementation specification. So that one we actually wouldn't have to get done and be compliant with in those 240 days from the finalization, just because a lot of business associates agreements are tied into annual contracts or renewal of contracts. But yes, it would require a new business associates agreement to be written up because it would require additional standards, implementation specifications, and compliance things. So that means we will need to get a new business associates agreement created and signed with each of our business associates, which also leads us into that annual business associate compliance verification. Great question. A recording of this will absolutely be sent out, and then we're going to try and send some additional resources that will answer questions, future questions, and we also invite you to ask questions.
Megan, one question that popped in here was would there be any federal grants to offset the cost to attain these changes? And I believe at this point we're not sure. We'd probably have to dig in a little deeper, but nothing has stood out at this point that I'm aware of.
Yeah, I haven't heard anything about a federal grant yet, but I do think that would be helpful. Oh, there was a question about the vulnerability scan and pen test being performed by a third party. There is no language requiring that is done by a third party. The vulnerability scanning basically just says automated, which means use a tool to do it. There is language in the penetration test that says it that basically gives the requirements of the person completing the test. It basically says they must have experience in ethical hacking or forget the other term that they use, but it must be completed by somebody with experience in performing a penetration test. So if you have someone in-house that can do that, go for it. Most people do not have that kind of experience on their team. We don't have a penetration tester on our internal team. We have a partner that does that for us. So if you do have someone who can do it, absolutely, but there's no language requiring that a third party must do it. You can do it internally if you have the tools and resources. That's a good question.
And the vuln scans, I got that correct. Vuln scans, vulnerability scans, we are capable of doing those. Um, yeah, looks like David had a question around. Looks like it's been answered already around BYOD, which is a great question. How does BYOD apply with these new changes? It's been really loose prior.
Yeah, I would say it's still pretty loose. There was nothing within the regulations that really spoke exclusively to BYOD. These same standards would still apply to the BYOD devices. You know, yeah, encryption, multi-factor authentication, things like that. But there is no specific wording on BYOD and guidance there.
We'll give another minute or so for any other questions. And again, if while we're waiting to see if any other questions come in, just a reminder that um, if you want a copy of the video or presentation, type in yes in the chat box. If you'd like for us to connect with you afterwards to review your risk assessment, whether we did it or another third party did it, to look together with you to see what the gaps are based on the proposed changes, we'll happy to do that at no fee, just to provide more information. This is again, this is our way of providing information to the community. Whether you have internal IT or another service provider that's already working with you, share this information with them. Make sure that they're prepared for these changes, prepared to help guide you on these proposed changes should they go into effect. All right.
There was one more question about MDM and partition of personal business applications on BYOD devices or typically mobile devices. There, again, is no real change in the regulations. There is one change that talks about network segmentation or logical virtual separation of data within different planes, which you could apply to BYOD partitioning of personal and business. There is that a new implementation specification for that segmentation of data because we're trying to stop any sort of lateral movements, but nothing that really specifically talks to mobile devices and nothing that specifically talks to BYOD or personal devices. But there are some things that we can gather and create our own best practices based on what is written, which is, separation of different data points, multi-factor encryption, etc.
Okay, it's right at 2:45. We appreciate everyone coming together today to work on to let us brief you on what's coming down the pike. We will continue to do this as information becomes more available to us. We'll continue to share that information out with the community. And in the meantime, again, if there's anything we can do to help you or your service provider or your in-house IT, please reach out to Megan, and she'll make sure that she brings the right resource to the table, whether it's her or one of our other team members.
Perfect. Thank you all. Have a great day.